Okay, I think we're going to begin. We have some wonderful case studies to explore at the end of the workshop, so I want to make sure we get to them. I want to introduce you to Dr. Christian Marks. He will be presenting the fourth and final Good Clinical Practice workshop in the series, When is Informed Consent Truly Informed? What you need to know is I'm going to put you into groups towards the end of the workshop, and I'm going to actually put the document that you need to retrieve the case studies from, and I will tell you which group is doing which case study. So please make sure that you can obtain the document within the chat so that you can find out what your case study and the corresponding questions are. I also want to remind you to please complete the survey that I either put in the chat or that I send a couple of times during the course of the week, because we use those in order to improve the series and also, of course, to report to our funding body. So that's really important. And finally, if you are in the process of working on the micro-credential, just keep working away. Everybody's doing a really great job. And I look forward to one of your final, the third assignment and your final assignments as well. I appreciate all the hard work you put into it. And with no further ado, I'm going to introduce you to Dr. Christian Marks.
Hello.
Take it away.
I'm going to take it away. I'm going to share my screen and so that I can get you the slides here. There we go. All right. Thanks for putting up with me for a little bit here. My name's Chris Marks, and I'm the director of the Social and Behavioral Research Support Center. And I think they asked me to do this one because a lot of the people over in the behavioral sciences tend to do a lot of different consent processes, more so than just, come in and it's all signed consent with a long form or something. They've got all kinds of different options. So they asked me to talk today about when is informed consent truly informed. And basically, I'm going to say that informed consent consists of three parts. We start with conveying information, then there's understanding on the part of the participant, and then there's an affirmative free choice. If I turn out to not be loud enough or need to turn something up, just give me a high sign if you would, please, okay? Follow that up with documentation of informed consent when needed. I'm going to cover the who, what, where, when, how, and sometimes why of some of the different things that happen with informed consent. And I'm going to take those out of order. I'm going to start with the what, and I'm going to cover the what fairly quickly. And the reason for that is because I don't want to spend a lot of time on something that you can really just access right direct from the slides, okay? So we're going to start with what to convey. The first thing to keep in mind is there's a correspondence between the IRB protocol, the HRP 503, and the consent information that's to be conveyed to the participants, usually in the HRP 502 document, okay? There's a correspondence between these, and I'm going to show you that correspondence to show you where the whats are coming from. Now, when I did this the first time, people said, this was great. We always get these consent forms from the study sponsor, and we need to figure out what to put into the protocol. And if we just do this backwards and reverse engineer it from what you've shown us, Chris, we can do that. That'll help us greatly. So keep in mind that may be helpful to you when you're dealing with something, when the sponsor gives you a consent document to work with. You can use that to help fill out the protocol, okay? So what to convey, okay? What needs to be conveyed first, okay? There are some required elements that have to be in the consent document, but you also want to include other information that would be pertinent to a reasonable person, things that somebody would be interested in knowing about the study before they made a choice to participate, okay? Informed consent needs to begin with a concise and focused presentation, okay? And then it should be presented in a way so that people understand what they're reading, okay? I like to say, I know you pull out the HRP 502 and you start at the top of it and you start trying to put together this this concise and focused presentation. No, don't do that. Leave that for the end. Go put the details in the bottom of it and then say, okay, what do I need from these details to fit in here so that you're consistent, and then you can make things more concise and do it that way. So I like to say, go to the detailed information parts first and leave the concise, focused presentation, the first page of it, for the end. Okay. Of course, there's a title. Okay. Grab that from the short title that you get from the basic information page of what you put and click. The reason I'm saying to use the short title is because that's what comes up to the IRB and to you when you're looking for this thing. The long title doesn't show up in your listing. Use the short title so you got a nice correspondence there. Okay. Inclusion criteria. There's a section where you're trying to figure out, why am I being invited to take part in a research study? And that should come right from the inclusion and exclusion criteria, right from Section 8 of HRP 503. Okay. Why is the research being done? Okay. That's another section of the consent document, which you can get right from the background, the study design, and maybe the study intervention or investigational agent. You can pull that information right into why is the research being done. Bring that in as your concise information for the purpose of the research. Time frame. Again, in the protocol, there's section 13 covers the study timelines. How long is an individual's participation in the study going to be? We expect you'll be in the research study for 1 hour, 1 to 2 hours, 3 to 4 months, 6 months to a year, whatever it is. Okay, you've got that timeline right in section 13.2, the duration of the subject's participation, including length of study visits, and you can expand on that a little bit if you need to for the consent document. Now, come back to, okay, the question that says, do the following after you've completed the detailed. You will be asked to and include the high-level summary. Is there any B-wing the study is going to be bad for me? Okay, wait on that until you've done the actual risk section later. And that section about, is there any way that the study could be bad for me, that's in the concise presentation at the beginning of the consent form, should just cover the most important risks. The main risks and all of them, and all the discomforts would go down in the detailed risks. Okay. Benefits, okay? You got a benefits section in the protocol right in section 24. Grab that. It can go right into filling out the HRP 502 in the consent document for, will be in this study help me in any way? What happens if I don't really want to be in this research? There's nothing in HRP 503 that covers that. Okay, there's nothing that lists the alternatives right in the protocol. You know those better than the IRB could. They're the relevant accepted treatment procedures in most cases, or there may be no alternatives. Okay, I get this from the behavioral people. Well, I'm doing a survey, there's no alternative for this. Well, just say your only alternative is to choose not to take the survey. Okay, it's a real simple answer. There are no alternatives. There's the only alternative is to choose not to take the survey if you don't want to. Okay, but you want to list alternative procedures. Okay. Number of participants, again, how many people will be studied, comes right from the local number of subjects or the multi-site research number of subjects, okay? And we expect that there will be 20 to 25 people in this research study here at ECMC, and there will be 200 to 400 people enrolled nationally. Okay, not a hard thing to do, but that's where you can get them from, right from section 7 and section 31. What happens if I say, yes, I want to be in this research? Tell the subject what to expect using lay language. This would come from your procedures, the setting, the study intervention and investigational agent, privacy, maybe banking of specimens or data for future use, and confidentiality. Tell them what's going to happen in a way that they can understand it. You will be asked to come for an appointment and an initial evaluation, at which time we will do a physical. Okay, we will then ask you to schedule a time to have an x-ray done. We will then provide you with the study drug. You will take it 3 times a day, whatever it may be. Okay, explain it to them in terms that they're going to understand. Subject responsibilities. What are my responsibilities if I take part in this research? Okay, if there are no subject responsibilities, you can delete that section. But often there is the responsibility to come back at least for all of the follow-ups and all the extra appointments to make sure that everything's working, and to take whatever medication is being provided, or things like that. Or maybe one of the responsibilities is to abstain from sexual activity because this might have a profound effect on pregnancy. That might be one of someone's responsibilities. This would come generally from the procedures. It might come from the economic burden section also, because there might be a cost that somebody's responsible for taking care of themselves, a cost or other activity that they have to take part in order to be a part of the research. Okay. Withdrawal procedures. What happens if I say yes but change my mind later? You can leave the research at any time. It won't be held against you. This would come right from section 22 on withdrawal of subjects. It might also come from the risk to subject section. Okay, there might be some portions of the risk to subject section that's going to help you fill that out. Okay. Is there any way that being in the study could be bad for me? Okay, this is the detailed risks to subjects. It's going to come from section 23, where you get the reasonable risk, discomforts, hazards, or inconveniences, any procedures being used to reduce those risks, any procedures which may have risks that are currently unforeseeable, because the treatment that you're offering is so experimental that we don't know what the risks of this thing is going to be. If there's any potential risk to embryo or fetus, should you become pregnant, and if applicable, describe risks to others who are not subjects. That one probably wouldn't go in the consent form, but maybe, okay? It could be, okay? If you're on this drug and your wife becomes pregnant, there may be effect on her due to that happening, okay? So there may be a risk to others that might be included right in the consent form, okay? Confidentiality will come right from the confidentiality section of the HRP 503, section 20, confidentiality of study data, confidentiality of study specimens, and from 32 for banking of data and specimens for future use. Can I be removed from the research without my okay? Okay. Are there any anticipated circumstances under which you may withdraw someone from the research without their consent? Look, if you become too sick, we're going to take you out of the research because you aren't going to be able to make the appointments. You aren't going to be able to stay on the drug. And then describe any procedures needed for early termination. That's going to go right into the can I be removed from the research without my okay? It might also be in the procedures, okay? And whether or not you're going to share any results with people, you might share results and say, look, this treatment really doesn't seem to be working for you, and we think that you would be better off coming out of the study and going back on the standard of care at this point. Anything else? What else do I need to know? Who's paying for the research? Who's paying medical costs? Who will pay for my medical care if this causes any harm to me? Will come out of the resources and qualifications section for availability of medical and psychological researches, compensation for research-related injury, and economic burden to subjects. It'll come out of those sections to fill that out. It could also come out of the compensation for participation, and it could also come out of 12.5 and 12.6 for sharing of results and alternatives. What will happen to information and samples? HIPAA and privacy. The HIPAA and privacy section of the consent document will basically come out of sections 18 and 20 for provisions to protect privacy interests of subjects and confidentiality of study data. Okay, now we've gotten through the what. Okay, thank you for bearing with me and letting me fly through those. I know you've got the slides, so you can go back and refer to them as time goes on when you need to do this. So enough on what. Who should conduct the consent process? Well, details of the consent process are again defined in your protocol, section 28.5, and in 28.5, 28.5, 28, not 26. There's one number I forgot to update. Okay. Indicate whether you'll be following the SOP informed consent process for research, HRPO 90. And a lot of people will simply check that box at the bottom of it. Keep in mind that when you do that, you are saying that you are going to follow every step of HRPO 90 in how you conduct your consent process. Okay. If not, in 28.5, you can include different roles for individuals listed in the application who are involved in the consent process. Time that's devoted, steps taken to minimize coercion, steps taken to ensure subjects' understanding. Okay, so you can do those things and still check 090, say I'm following that, but here's some extra things that I'm doing. Okay, so who should be part of the consent process? Remember, there are implications for understanding an affirmative choice in who conducts the consent process. So according to the rules first, who can conduct it? Well, it's got to be someone that's indicated in your CLIC application that that member is conducting the consent process. It can't be just anybody. Okay. Yes, assume the investigator would be doing it, but anybody else, you really do need to say that they're involved in the consent process. Otherwise, they shouldn't be doing the consent process. Okay. But that's who can. Now, who should? Okay. The person should be knowledgeable. They should have sufficient knowledge about the procedures, the alternatives, the potential outcomes. They should be able to answer questions. They need to be someone that's a good communicator. They need to be able to devote sufficient time to the process. Often, the surgeon doesn't have the time that's necessary to do this, but this may mean that you need to really educate the person that's going to be doing the consent process with the participants, so that they can answer questions and minimize some of the time that you're going to need to take in part of it. The person should not be in a position that would create an undue influence to participate. Okay, and they should not be financially conflicted. Keep in mind, though, consent doesn't have to be the domain of only one of your personnel. You could have one of your associates conduct the beginning part of the consent process, go through the document with a person, answer any questions that they have, and any that they can't answer, say, look, I think Dr. Smith would be better at explaining that, so I'm going to bring him in after we get done with any of your other questions so that he can answer that question for you. Okay, so it doesn't have to be a one-person deal. You can take a little bit of time with it. Who else could be included or involved in the consent process? Well, you could include family members. You could include the subject's primary care physician. You could include a clergy member or an advisor, someone that the person trusts, to bring in to also be involved in the consent process. Now, they're not going to be doing the conveying of information, but they might be able to help someone understand what they're getting themselves into at that point and help them to make that decision. Okay, so considerations for who, okay? And this is, I took all these considerations for who, what, where, when, how, and put them at the beginning of the handout that's going to get passed out with the case studies on it. So don't try to copy them down, okay? But keep in mind, you need to make sure that the research, ask yourself these questions. Are the research team members qualified? Okay. Are they good communicators? Do they have the time to be able to do this? Okay. Do they can they conduct the consent process in the subject's preferred language? And what languages other than English are they capable of doing it in? Okay. You may have people that can do that. Okay. Is there any potential for unintended undue influence by certain team members? Is there another team member who can eliminate or otherwise mitigate that? Do we need more than one study team member involved? Why or why not? And should others, family members, primary care physician be involved either in all cases or for certain situations? It's not an all or nothing. It doesn't have to be in all cases, okay? When to convey consent, okay? Consent doesn't have to take place overnight. It's an ongoing process. Okay. It doesn't have to take place here. Read this, sign it. Okay. Hopefully you don't have to have that situation. It doesn't have to happen right away. Keep in mind that your recruitment process begins the consent process because you're starting to convey information there. Okay. In your protocol and the recruitment methods, it says to describe how, when, and where potential subjects are recruited, describe how their privacy is protected. But 11.3, identify materials that will be used to recruit subjects. You can use that and say that actually begins to tell people how long they're going to be in the study, what is involved with it, what it is, whether they qualify or not, and what the benefits that they might be anticipating from it are. Okay, so recruitment begins the consent process because you're conveying information. Now we start looking at HRP 090. Okay. And I'm going to start talking about the long form procedures. Okay. You check that box. Okay. If the consent process is going to be documented in writing with the long form, okay, provide the copy of the consent form ahead of time, in advance of the consent discussion. Give them a chance to look at it ahead of time. Maybe it's done when you set up the appointment. Okay. I recently needed to have a prostate biopsy. Okay, it all came back negative, so I'm very happy about that. Okay, but when I went for when I scheduled the appointment for the biopsy, the woman on the phone told me some details and highlighted a few things, and then she said, "I'm going to send this all to you in the mail, and I'm going to highlight these parts that are most important about not eating and using an enema the morning before and things like that." Okay, so she sent that to me. I thought about that and I said, this is providing the consent form for me ahead of time. Yes, there was still paperwork to fill out when I got there. Okay, but this is the equivalent of, we do this for other procedures. Why not provide the consent document in advance of the consent discussion? Okay. 5.2.6, read the consent document and explain details in a way subject understands what it would be like to take part in the research study. Okay. Is the other part of when consent's going to happen. Invite and answer questions. Okay. Give the subject representative time to discuss taking part with family members. If they've got it ahead of time, then they can talk to their family members. I was able to talk to my wife about the biopsy procedures before I went in for it. We decided whether or not I needed a ride or not to get there. And no, I could drive myself home. Not a problem there. Okay. Invite them and encourage them to take the written information home, to consider it and discuss the decision with their family members. Okay. So you want to try to encourage that type of thing in the procedures. Now, it doesn't matter whether you're using long form procedures, short form procedures, or verbal or oral procedures, you still have those options all the time. Okay. I'm just using the long form rather than try to show you all three of them. Okay. The consent process. Okay. Section 28.3 talks about describe how you will ensure the subjects are provided with a sufficient period of time to consider taking part in the research study. Now, sufficient is procedure dependent. Think about it. If I'm going to fill out a 20-minute online survey, a sufficient amount of time is probably 3 minutes. I can read the document. If I have no questions, I can click the button and I can go and take the survey. Okay. But although it's really an unlimited amount of time, I don't have to click the button. I can read the thing and I can come back to it, a day later and choose to click the button to go in and take the survey. Okay. But if we're talking about something that's going to potentially affect their health, long-term side effects, things like that, it probably should be a longer amount of time. Okay. It is always a requirement that they have sufficient time. Okay. The IRB judges whether what you say you're putting in there is sufficient. Okay. How they make that judgment, I don't know, but I think usually people they'll trust the clinician on that as long as it's not way too short. Okay. Describe any process for ongoing consent. describe the subject's willingness to continue participation for the duration of the research study. Again, for the 20-minute survey, you don't need it. It's not needed. Even for an hour-long interview, it's probably not needed. On the other hand, if you've got to have the person come back for multiple visits, you should build into your process a time where you're going to say, look, remember, this is all voluntary. You know, if you want to stay in the study, you do need to keep doing it, but you don't have to stay in the study, especially if you're finding that this is causing you a lot of discomfort along the way. Okay, there should be processes to ensure that they have a chance for ongoing consent. So considerations for when. What timing should be used in order to allow sufficient time for participants to consider the information, have their questions answered, and discuss it with others before making their decision? What are the circumstances for this particular study, if any, that point toward the need for an ongoing consent process, where you might formally review consent information throughout the study? And are there any circumstances related to participants' condition that would make comprehension of information, understanding, or decision-making more or less difficult? Can the timing of the consent process be altered to minimize the negatives and maximize the positives? Ask yourself that question, okay? Where consent should be conveyed? Location, 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 okay? In 28.2, it says describe where the consent process will take place, include steps to maximize subject privacy. I don't know about the medical protocols, but I get a ton of protocols that I pre-review, and it says describe where the consent process will take place, and they tell how it's going to happen, and they don't say where. Okay, that where is important. It should be in a private enough setting and in a quiet enough setting for the procedures that are involved. Okay, you're not going to want to do it in the waiting room, probably. You probably want to do it in the exam room or a conference room or something someplace else. Okay, although I can think of some studies where doing it in the middle of Tim Hortons might be just fine. Okay, so someone's meeting a teacher to interview them, you know, and then they say we're going to talk about teaching things, you know, and I'm going to buy them a coffee while we're doing it. Could you do the consent process at Tim Hortons? Yeah, if it's quiet enough, although sometimes I've been in Tim Hortons and it gets pretty loud. Okay, but there's enough, it's private enough of a setting for that type of study. But if you're talking about something like prostate health, of course, in that case, private enough setting was not Tim Hortons, of course. Okay, so you want to do that in a private enough setting or a quiet setting when appropriate. Conduct, if you've got children involved, you might need to conduct the consent process for children either in the presence or absence of their parents or legal guardian. There's this television show that's on 24 hours a day, 7 days a week right now called Law and Order Special Victims Unit. And sometimes they have the kids' parents present, and sometimes they don't have the kids' parents present when they're interviewing them about sexual abuse in this case, okay? Because sometimes they want the child needs to have the parent there for support, and sometimes the child is afraid of saying something because their parent is there. Choose a location where there are no distractions. It's difficult to learn in a crowd or with the TV on. Choose a location where the subject can be at ease. Use a conference room rather than an exam room if available. Choose a location on the subject's turf. Offer to meet them someplace other than the office if that's possible. Okay, consider different alternatives for different potential subjects, even if they cost us some additional dollars or effort. Create an atmosphere of equality. Okay, consider who has the big desk and who's wearing the gown that ties in the back. Okay, if you can, you'd be better off doing it at the desk, but you'd be better off doing it at a table if you can. Okay, and of course, there are circumstances where there is no choice due to the patient's condition. Okay, you're already bedridden. We can't take you out of the gown. We got to do it in the patient room, and this is really the most private place you can do it. So that may be something that we're stuck with. Okay. Considerations for where. What locations are available for the consent process? Keep in mind that different locations can be used throughout the process. Okay. You might have initial consent occurs in that table meeting room setting, but ongoing consent might occur, in the procedure room. Are the locations free from distraction? Okay. If not, then you can't possibly obtain informed consent. Are the locations sufficiently private? Is this a private enough spot where people aren't going to be overheard by people that they wouldn't want overhearing them? Okay. Uh, you know, my wife had an ER visit about a year ago, and I thought about it, and I said, we were at Buffalo General, and I thought about the rooms in the ER were certainly private enough for the situation that she was in, but I thought about where she actually had to give her consent for having some tests done, and she was on the gurney in the hallway. And I thought about it, I said, geez, was that really a good place to do that? I realize that you limited resources and things like that, but and limited places where you can do it. But the gurney on the hallway might not have been the place that was sufficiently private enough for obtaining consent for some procedures. For hers, it was so that they could do an MRI. Okay, who cares? Okay, not a big deal. Are there other locations available where the subject can be more at ease that also minimize the potential for undue situational influence? Considerations for where. How to convey, and I'm going to again say using the long form of consent. Okay, keep in mind, if you're going to document in writing with the long form, you got to follow all of those steps from 5.1 right through 5.6, and then I think there might be a couple more after that. Forgive me. Okay. Make sure you got the current one. Verify that it's the current one. Give a copy to the person, to the subject. Provide the consent form in advance. If they can't read, then you're going to have to read it to them, and you're going to have a witness that it was read to them. If they can't speak English, obtain the services of an interpreter. Okay, get the interpreter in. The interpreter could be a family member. It could be a member of the research team. It could be a friend of the subject or their representative. I like the research team myself, if you can do that, because then they're going to be able to not have the question interpreted and lose the question in the interpretation. Read the consent form or have an interpreter read the translated consent document with the subject representative and explain the details to them. Okay, that's the how parts of this. You then need to invite and answer questions. Okay, it's not just read through it and sign here. Okay, invite them. Do you have any questions? You might even ask them a couple questions so to get them started. Okay, give them time to discuss it. Okay, invite and encourage them to take it home. If they have questions, provide factual information and avoid statements that imply that compensation or treatment is never available. Okay, so if they ask, if I'm injured here due to this procedure, who's going to pay for the treatment? You should. Will I get treatment? Well, yes, we will treat you. We may need to bill your insurance at that point. And if your insurance won't pay for it, you would still be responsible for the additional cost for that treatment. Okay, provide the facts. Okay, as Jack Webb used to say on Dragnet, the facts, ma'am, just the facts. Okay, I know that's an old TV show, but it's still on reruns. Okay, be creative with the following. 5.16, read the consent document or have the interpreter do it. Okay, I hate to say it. I know the directions say read the consent form to the person. If I had someone sit down and start reading through the consent document with me, I've looked at so many consent forms, I think I'm quitting the study. Okay, I think I'm saying right there, look, just give me the information. I got a PhD in chemistry, and I'll ask you questions. I did this for a living for a while, did consent documents and protocols. Let me read the thing myself, and I'm going to make notes on it while I'm going through any place where I got a question. So maybe there are creative ways to do that. I know it says read the consent document. Maybe that's one of the things that you want to say that you're not going to directly follow from HRP 090 when you write your protocol, because there might be better ways to do it. A slideshow, a video presentation, additional reading materials and websites, taking them through a simulation of what it's going to be like. Okay. I guess one of the simulations that I had before the issue that I had with the prostate test, I had a friend and I said, so how bad is it? And my friend told me it's no worse than getting a tooth filled. He says the pain is no worse than getting a tooth filled. And I said, okay, that gave me an example that I stopped worrying about it ahead of time and just went and had it done. Okay. Referring someone to a previous subject. Okay. Again, get the former subject's permission first, but they can maybe help to explain it. This was my friend that I sing with at church, and I asked him what it was like, and he gave me some information, and it really put my mind at ease about the procedures that I was going to have done. Okay, so be creative with that read the consent document to the person. There may be better ways than just reading it. Okay, considerations for how. Am I following the regulatory requirements of HRP 090? Is there anything else that can be done to aid understanding in the voluntary nature of their decision, the risks and benefits, and what it will be like to be part of this research? Okay, is there anything else we can do to aid that? Can we reduce pressure to make a decision due to time or other factors? Okay, can we give them more time, or I understand sometimes time is of the essence, but can we reduce that pressure if possible? How will we determine whether or not a person's capable of consent? Should there be a formal process given the population? Okay, if you got a population that might not be capable of consent because their mental facilities are deteriorating, or maybe they physically can't indicate their consent in any way. Okay, how do we going to determine that? Is there anything that should be done differently to help ensure the participant is able to freely make and communicate their decision to be part of the research? Okay, those are some of the things to think about for how. Understanding, okay, aka comprehension. Keep in mind, there's a big difference between knowledge and understanding. I can know how to take a derivative mathematically, okay? But do I understand what that means mathematically? Okay, that there's a difference there. Okay, understanding requires the ability to interpret knowledge. It's just not, again, in this case, it's not just the facts, ma'am. It's making sure someone understands what they're working with. Okay, what needs to be understood? When does it need to be understood? Keep in mind information. Not all information needs to be known by the participant throughout the study. Okay, they don't need to know everything at every second. Okay, they should be introduced to the important things and all of the information at the beginning, but after they've made a decision, it's okay for them to forget about some things. Okay, yeah, don't forget to take the medication daily, but do you remember, tell me, do any of you know when your next dentist appointment is? No. You know? Oh boy, I don't know when my dentist appointment is. Okay, I know it isn't until June or July or something like that, and I got it on my calendar, but I've forgotten when it is because I wrote it down, and I can look back and find out when that is. Okay, there's some information that should be understood throughout, like the voluntary nature, and that they are making a choice as a participant, but they have access to that information that they might have forgotten which is why we give people copies of things. Okay, there are some things that you don't have to know throughout the study. You might have a process where when someone comes in for a given procedure on a given day, you run through what that day's procedures are. Do they need to know about next week's procedures? No. Just talk to them about today's. Is that still going to be okay with you? Okay. So make sure that they understand what's happening in the moment. Okay. How can we help to ensure understandings? Okay. Many of the things that we did in the process of conveying information were not as much for conveyance as for helping to ensure understanding. The materials ahead of time, the materials plus the discussion in the participants' preferred language is for understanding. Inviting and answering questions is for understanding. Giving time to take it home and discuss it with other people is for understanding. Providing the description of what it would be like to take part in the research study is for understanding. It's not necessarily for conveying, it's actually for understanding. I'm one of those people that when I want to understand something, the best way I can understand it is to teach it. Okay. So I like to go back and say, okay, how would I explain this to someone else? And then I really start to understand what I'm doing. Or sometimes I've got to actually verbalize it and say, oh, think it through, and I'll talk to myself. And my wife says, "You're crazy, Chris." No, I'm figuring this out, dear. Give me a minute. And it's just my way of understanding and getting a hold of things. Okay, give people their chance. Methods of conveying information may need to change over time. Keep in mind, the children grow up and gain the ability to understand, and certain conditions can lead to lessened cognitive ability and a lessened ability to understand. So keep that in mind when you're dealing with understanding. Someone may be capable of understanding and knowing what the procedures are today, and 3 months from now, no chance. Okay. How can we help to evaluate understanding? Well, HRP 090 covers a bit of that. Ask the subject representative questions to determine whether all of the following are true. If they understand the information, they don't feel pressured. Ask if they're making a voluntary choice. Are they capable of communicating an informed choice? Okay, so you might want to ask them some questions. Okay, we're not looking to quiz the participant, but rather to engage him or her in conversation. Okay, so you might ask someone to explain back to me what you think is going to happen when you undergo this procedure. Okay, what's your understanding of it? What do you think is going to happen? So you're not quizzing them. You know, it's not like there's a right or wrong answer, but you're engaging them in conversation. Okay. Affirmative free choice. Remember, being a research participant is voluntary. Nobody has to do it. Okay. Again, back to HRP 090. The process begins when an individual identifies a subject as a potential candidate for a research study. So once they're recruited, you send them the materials. That's where the process begins. It ends when they either give consent or decline to do so. Okay. Once they say, no, I don't want to be a part of this, the process is to stop. Okay. Again, the regulatory, that's what you're committed to. But the consent process, describe consent process for ongoing consent. Again, that's where you're going to have that described. If the research involves a special population that's considered vulnerable, describe the safeguards included to protect their rights and welfare. That's another place where you're going to describe some of the added procedures for vulnerability of populations. Okay. Keep in mind, lack of objection is not an indication of agreement. External influences need to be minimized. Your own position as a healthcare provider could be an undue influence that's sometimes unavoidable. Okay, so think, is there a way that we can minimize that? Signing the document is only an affirmative. Signing the document is only an affirmative choice. It's not the choice itself. Affirmation of choice. I'm sorry. An affirmation of choice. It's not the choice itself. Okay. It's just a documentation. It's not the choice itself. People make the choice when they pick up the pen and go to sign the document, not the choice itself. Okay. Remember, informed consent's a process. Conveying information, understanding, affirmative free choice, followed by the documentation step. Okay. I have now contact information for myself there, which probably the best way to get me is just Marks, M-A-R-K-S at buffalo.edu. I know I'm giving you this before we go to the simulation exercise and go to the case studies, but I figured better to get it out there right away. I'm happy to talk to anybody about any problem you've got or any issues you may have in the future. Even though I'm the behavioral office, I don't distinguish if somebody calls me up and says, "Hey, Chris, I saw your presentation. I'm calling you up about this. What do you think I can do with this problem with the IRB protocol that I'm having a difficult time with?" I'll be happy to talk to you. I may get to a point where I say, well, one piece of this is about credentialing at the hospital. I don't know how to do that. You may want to talk to the clinical research office about that part, but I'll work through things with you and talk it through with anybody. Okay. So we're now going to have our simulation exercise. Okay. And I want you to keep in mind that all simulations are imaginary and somewhat unrealistic. Okay. You the case study that you're going to be assigned is probably not going to be one that you would be dealing with in your field because it's imaginary. Okay. But there should be some parallels that you can glean from the application to your own particular situation or your future situation with research consent. Okay. There's going to be some constraints on you. Okay. To encourage some flexibility and adaptation, but allow you to be creative. Okay. And hopefully this is a challenge to you. Okay. No one likes to do crossword puzzles for first graders. Okay. So I hope that this gives you some sort of challenge. Okay. So once we break out into groups, your members of your group are going to be the research team. You're to pick a PI. Don't spend a lot of time deciding who's PI. Just pick somebody, okay? And don't pick somebody because they're the most experienced person there. Make your most inexperienced person the PI if you want to, okay? The principal investigator, because then they're going to be able to learn something else, okay? Use the guide for developing an informed consent process to help you decide on how your team will obtain informed consent and then answer the questions below the case, okay? Your PI will be asked to present your answers and reasoning, okay? The ground rules. The PI has all the knowledge capable to do the study procedures and the skills to carry out the research. Your other research team members are restricted to only what they know, okay? They can't assume new knowledge, okay? So if there's going to need to be training or something that happens, then that should be a part of your process. You can use any facilities or equipment that any member of your group can already access, but you can't create the facilities out of thin air, and you're limited by your current job responsibilities. So if you have clinical duties that would make it impossible for you to be around and available for questions 24/7, then you need to work around those duties. Okay. Now I'm going to click to exit the slideshow. I'm going to unshare my screen, and you're going to break them out into groups for me?
I am. The case studies are in the chat, so please look at those. If you are in room 1, you're going to take case study 1. If you are in room 2, you're taking case study 2. We have enough for 3 case study rooms. So if you're in room 3, you're taking case study 3. Case studies begin on page 4 of the document in the chat, and you're going to get approximately 10 minutes to work on this. Does anybody have any questions as to what you are to do?
And then we'll come back at that point and each group can present their case study for 5 minutes, and hopefully we won't just read through what's on the paper, okay, because everybody's got the paper, okay. So we've all got that ahead of time, so we can spend 5 or 7 minutes per group saying what you did, and then we can take time for questions at the end. That works?
Okay. So I'm going to open the rooms and you're going to get 10 minutes. Any final questions? I'm going to open the rooms now.
Okay. So I hope you found the cases that challenging, at least, for what you're looking at. I guess I'll start with saying case one. We'll just take them in order. Case one: differing perceptions of risks and benefits. If the principal investigator, whoever's representing the group, could no need to reread the whole thing, because we all have the sheet with that on it. We can take 25 seconds and take a look at it, but tell me what your answers were, and tell me what some of the situations you saw were, and some of the answers to the questions that you came up with. And I'll shut up now, and
And I just want to tell you that some groups did not have a time to address all questions, so they're just going to probably address what they could address. Oh, they don't have a mic or video, but for question one, they said the subject may be minors.
okay. Yeah, I would agree. The subjects might be minors, so we're going to get them from the chat.
I think in this case, we're going to get answers from the chat, so they're going to send it into the chat. So if you want to ask them a question or address a question with them, then I will read their response from the chat for you. Does that work?
So, well, the issues are, yeah, what are some of the issues presented in the case to obtaining informed consent? Is it a communication and understanding, or ability to make a free decision? Do you think that being a minor would cause a problem in which of those areas, or would it not be a problem?
Understanding, they wrote. It could be an understanding issue.
Yeah, I would agree. We got an understanding problem there. So who did you think should be involved in the consent process in that group? Who would you have had doing the consent process?
All family members, they wrote. For minors, the parents' guardian should be involved.
Who from the research team?
A family member with a subject as LAR and coordinator as witness.
When would you have the consent process take place? And would there be any ongoing consent for this type of study?
The worry is that the document does not say where the consent will take place.
Where would be a valid question. Where would you have the consent process take place? Are there any special, I'm not saying on the corner of 4th and Oak,
Okay. But it says you will conduct focus groups and in-depth interviews with individuals and family members. So wouldn't all family members need to consent? Good question.
Yes. All the people who are going to be there for the focus group would need to consent. Okay. But not the family members who aren't present for the focus groups. Okay. So you might need to have the consent process with all of the participating family members in this case. Okay.
Yes.
Okay. Do you have any special things for any special processes for how you would obtain consent? Anything different that you would plan on doing?
Right. Is this an open meeting area? The family and subject need a private, quiet area like an exam room.
Okay. You think you need a private? Okay, that'd be fine. And what type of do you need any added resources? You think you probably need that exam room, but was there any special resources you thought you'd need for that one?
Special resources.
No.
Any special resources are needed.
Anything special you'd do? You'd use PowerPoint in this case. Okay.
PowerPoint to show and explain the study better. Okay. That's kind of like a question. PowerPoint to show and explain the study. Yes, visuals they're looking for.
Visuals. Okay. Let's go for case 2, and hopefully you have a microphone.
Thank you, group one, for
Thank you, group
adjusting
one.
and allowing us to still read your results, read your answers. So that was really good. You just did it differently. So case study two.
Group two. Group two is the family involvement informed consent. This is the study of postpartum depression. Who's the leader?
Go on to group three and see if we can come back to group.
All right, we'll try group three. Case three, hide and seek, developing technology for people with dementia and Alzheimer's. We got a group three person with a microphone, and come on.
Hi,
Hi, Wanda, I can hear you.
Wanda.
I'm gonna talk for group two.
You're group two.
Yeah.
Okay, good. We'll do group two then. We'll go back to group two then. Family involvement
For
informed
the
consent.
specific case study, I have experience on perinatal mental health studies. For mainly from our inclusion criteria, we used to say that we included women where the husband also agreed to participate in the study. Mostly we tend to use this as an inclusion criteria because we already know, because it's a family issue.
Okay.
Mostly, and even in some culture, women cannot take decision without the husband. We used to add this in inclusion criteria.
So you would include it in the added to the inclusion criteria.
Yes,
that your husband was willing to allow you to do so. Okay, that's good. That's good. So that's definitely a unique. That's a great way of potentially addressing it. You know, your husband would be willing to allow for this for the given cultural situation. So would you then, and I'll ask, still allow the woman to make the choice out of earshot of her husband with a yes or no for the final decision?
Most of the time, when the husband is agreed to participate, it's better, because for mental health, there is a lot of evidence that when women are depressed, men also tend to get depressed. We used to add both of them in the study.
So you want to expand the study? Okay, that's good.
Yeah. That's why for perinatal mental health study, we tend to add both the pregnant women and the husband, and we follow them.
Okay. So who's going to be involved? Obviously, the husband's involved in the consent process. Who from your research team is going to be involved in the consent process? Anything special there, or is it just going to be the PI or? Not
because that's of study. PI don't really have time. We train some member.
Okay.
We train some member. They are going to the prenatal visit site.
Okay.
That's where they usually meet these women.
Okay.
They meet these women. Then you cannot do that in the waiting room. The waiting area, you cannot do that. If you do that, those women, some of them, they won't show up. They won't show up. They will wait. They will just take the number and waiting. When the number appears, just enter the room for consultation.
Okay.
Most of the time, most of Obgyn also involved in the study team. Some of them invited women whether they want to take part, and if they say yes, they want to. That's when they bring the informed consent form. They are going home with this paper, and the husband have to read it also.
Okay.
Then they send it back. After sending back the consent form, that's where you are going for the first evaluation.
Okay. So were there any other issues that you know, from the who, what, when, where, how, or why you would want to highlight from that situation? And that's what I'd rather hear. You know, if it's nothing out of the ordinary, no need to. I
don't think there is anything more, because the way you do it, they do not provide it at the same place.
Okay. So do we want to try group three now?
I do appreciate the cultural responsiveness of the last response. That was really wonderful. Thank you for adding that. Anybody from group 3?
Looks like,
We're connecting to audio, hopefully. Okay, okay, we have a chat. Case 3. 1, answer to 1, not free decision. Participants may not be able to understand and remember the information.
I agree.
This is 2, research team. Caregivers and legal representative. Participants have limited autonomy before and during the process.
Okay.
For 4, quiet and outside the examination room.
Okay.
5, to avoid undue influence of the PI being the managing physician. And then 6, they said yes, visuals and videos would be helpful. Thank you for
Okay.
typing that out.
I actually had a situation like this. There was this was the tagging of the electronic tagging. A friend of my father's that he worked with was the gentleman that was lost in the Tonawanda Woods off Niagara Falls Boulevard for 4 or 5 days and died due to exposure about 4 or 5 years ago. So I had an experience of that exact situation of the tagging. You know, I mean, he wasn't tagged. Had he been tagged, he would probably be still alive today. You know, this was a gentleman that my father used to take me to basketball games with when we'd go to see the Canisius Bonaventure Niagara series down at the auditorium in the 70s, and he used to go and watch the games with us. So sort of strange, but okay. I guess I'll open it up now, you know, for questions. We're at 5:15, and I'm happy to answer any questions that someone may have. We've worked through our cases. Feel free to look at the other ones, you know, that I know there's 8 of them there. I'm always over prepared for these things, you know, but if you want to do them, use them with your class. I did put the reference to where I took them from and adopted them from. So, please take oh, that's the value. So,
Yes.
anybody have any questions? If you want to just put them in the chat or open up your microphone and jump in, I will try.
Oh, for case 2, there's a question. For case 2, what about those who are not married or having issues with the husband? What would you do in that situation if the husbands are involved directly in the case?
Well, in that case, that person I think would be consenting themselves and wouldn't need to have the husband's involvement. The issue here was that that culturally there was a husband, a woman that wanted to have a husband involved. In the case, if they weren't married and or having issues with the husband and wanted to be in the study, I think they could consent for themselves. But that does raise a point that there might be cases where you might have consent of the woman and the husband and just consent of the woman, you know, that you might want to build that into your process for if the husband's not involved in her life or not married or the significant other, the other half of who created the child, okay, is not involved. That would be
build that right in, so don't make sure that you're narrowing yourself too much then, correct?
Yeah, one tip I will give you all to think about is if you're ever writing a protocol, write it as broadly as you possibly can for the scientific condition that you're studying, okay? And what I mean by that, and I'm going to use an education example, if you need 4th grade teachers, don't say that you're going to get 4th grade teachers from the East End Elementary School. Say you're going to get 4th grade teachers, because there's no reason why not to include a teacher from the West End Elementary School if they'd still be a valid participant in the study. Now, contrast that with if there's a specific program, like we have the Alberti Bullying Center on campus, and that program's being only done at the Amherst schools. well, then you would restrict it to fourth grade teachers at the Amherst Central Schools. Okay, you wouldn't want to include Williamsville or another school. So when you're thinking about what you're doing in your protocol, write things like inclusion criteria to be what they're scientifically necessary for, and think about your consent process for being what you're going to be scientifically necessary for, or what situations might crop up. Okay, this one was a woman and husband, but it could be woman and significant other, who it could be woman and wife. Okay, for that matter. Okay, that could creep into that. Okay, thanks for
Okay.
having me.
Thank you. And if there's no other
Thanks.
questions, then I thank you so much for attending, and thank you, Dr. Marks, for your excellent presentation.
Thanks for having me.
Have a good night, everyone.
Bye.